Depression is a highly prevalent disease in the United States, affecting 8% of all adults and causing over 41,000 deaths in the year 2013 alone. Not only is this disease debilitating to the individual, but it is also causing a heavy burden on the healthcare industry. It's reported that 14% of all women of childbearing age have depression, and that only half of pregnant women are receiving treatment. Several factors are attributed to depression seen in early childhood, parental relationship and parental control being two. Children who perceive their relationship with their parents to be closer rather than more distant report lower levels of adulthood depression. Children who report inconsistent, strict, or overbearing parents have higher levels of adulthood depression than those who have more accepting parents. Antenatal depression and maltreatment are the two leading causes for adulthood depression. Maltreatment being defined as any form of emotionally inconsistent, disturbing, and in particular abusive and punitive treatment. In the year 2010, 700,000 children reported some form of maltreatment, and half of those cases had the mother as the perpetrator. So what does this mean for healthcare? Trajectories for depression start in utero, leading to intergenerational transmission. If the mother has antenatal depression, she sets the child on track for adulthood depression. So we need to stop the cycle. There are two critical periods that we need to intervene, the first being when the woman enters childbearing age. What I suggest is that we implement some type of depression screen into routine checkups, especially during pregnancy, and treat the mother before she becomes pregnant and especially throughout her pregnancy. In addition to the depression screen, we need to also implement parenting classes. Mothers who screen positive on the depression screen should be enrolled into a form of parenting class. Since mothers contribute to half of maltreatment cases, it makes sense that that's who we would be targeting. This does not mean that the classes would be limited to the mother. In fact, we encourage the father to come as well. But it's been shown that trends in father's form of parenting is modeled after how the mother parents. So if we target the mothers, in turn, it should affect how the father parents as well. Maternal health and parenting skills have been shown to be the largest contributing factor to adulthood depression through exposure in early childhood. The other critical time to intervene would be when the child reaches middle school age. A study of resilience to childhood stressful situations and to physical and sexual abuse showed a long-term value and effectiveness of having a close relationship with a stable adult as protection against depression in adult life. So what I suggest we do is we implement some type of big brother, big sister program for these children. When the mother gets identified as positive on the depression screen before pregnancy, we would keep track of her child. Once the child reaches the middle school age, we would implement them into this kind of a program. Not only would this program increase stability within the child's life, but it's also been shown to have remarkable outcomes in how the child performs later on in life. In a study following boys who are participating in a Big Brother, Big Sister program, it showed significantly higher self-concepts after participating. This intervention has been shown to be an effective means of primary prevention by providing necessary social supports. Not only are these programs already developed and easily accessible, but they're effective means to treat this issue. We already have depression screens for the elderly and for postpartum, so all we need to do is start implementing it earlier. By implementing it once the woman becomes a childbearing age, hopefully we can break the cycle before she even becomes pregnant and puts the child on track for depression. In addition, we would be providing secondary intervention with the Big Brother, Big Sister program. Because Bloomington is a large college campus and we have many college students available, they would make great mentors for these children who are in the Big Brother, Big Sister program. This would reduce the rates of adulthood depression, but it would also increase health outcomes in the long run.